Good afternoon, colleague. Welcome back to second session on the track 2 of Abu Dhabi International Mental Health Conference. Let's introduce our chair today, Dr. Deepak. He is a lead of Intellectual Disability Psychiatry Clinical Academic Group at Al Amal Psychiatry Hospital, Dubai, UAE. He has 20 years experience of clinical leadership, research, and academic experience as a consultant psychiatrist in UK. Dr. Deepak, he has several multiple roles in RC Psych examination, member and advisory appointments committee, CSER Article 14 evaluator and intellectual management committee. Please welcome Dr. Deepak to introduce our eminent speaker for today.
Thank you very much, Dr. Ahmed. Thank you for the kind introduction. Good afternoon to all delegates. Welcome to the conference, and I hope you're enjoying it. It's really fascinating to see so many esteemed speakers. Okay. It's my pleasure to introduce the first speaker of track 2 for this afternoon, Khawla Barley. Now, Khawla has drawn upon her background in management and experience in teaching to passionately deliver inclusive recreational programming for individuals with intellectual disabilities and autism throughout the UAE. In 2014, Khawla founded Goals UAE, a community-based initiative which pioneered the implementation of sustainable recreational programming for children with autism in the UAE. In her current role at Special Olympics UAE, Khawla continues to expand opportunities for the growth of individuals with autism and intellectual disabilities throughout the establishment of programs like Unified Robotics, which is the first nationwide program promoting inclusion of POD within STEM in the region. Through community collaboration and family engagement, Khawla advocates for the establishment of recreational and vocational opportunities for individuals with intellectual disabilities and autism across sports, arts, and STEM. Khawla today will be talking about a virtual unified sports model and promoting social connection for individuals with intellectual disabilities and autism during the COVID-19 pandemic. So without further ado, over to Khawla Barley. Thank you very much. Talk in a little bit. So it gives me pleasure now to introduce you to two speakers, Dr. Tracy Roque from the UAE and Salowa El Azabi, also from UAE, who are going to be talking about tocophobia, the fear of childbirth. Dr. Tracy Roque is the head of education and student affairs, the deputy chair for resuscitation committee, as well as an active member in the research and ethics committee at Danat Al Emirat Hospital, Abu Dhabi. Dr. Tracy is a registered nurse and a certified advanced midwife, has been awarded with a DBA, MBA, MSc in healthcare management, and has a Master of Applied Business Research. She's a qualified hypnobirthing instructor and has a diploma in aromatherapy, herbalist, and reflexology and naturopathy. She has a great passion for quality midwifery care, obstetric emergencies, and pioneered all the first private hospital water births in South Africa. Tracy is also a certified BLS instructor, NRP instructor, as well as a prompt instructor. The second speaker in this talk is Salowa El Azabi. At present, she's a nurse manager for the antenatal and postnatal ward at Danat Al Emirat Hospital. She's a prompt and NRP instructor at Danat Al Emirat Hospital. She also actively is involved in the following committees: the Laboratory Users Committee, Leadership Management Committees, Shared Governance Documentation and Informatics Council, and the Resuscitation Committee at Danat Al Emirat Hospital. She acts as a nursing supervisor on a regular basis. She previously was a charge midwife at Danat Al Emirat Hospital from March 16 to October 2019. Salowa has a bachelor in midwifery from Moroccan Institute of Health and Science and is currently busy pursuing her master in business management. This sounds like a very interesting topic, tocophobia, the fear of childbirth. So over to you, Dr. Tracy and Salowa. Thank you very much.
Hello, everyone. My name is Tracy Roque, and I am Head of Education at Danat Al Emirat Hospital. Today, we're going to be talking about a very important topic, which is tocophobia. And I'll be joining with Sawa, who is the unit manager of the antenatal ward, in a couple of moments or so. So tocophobia, the fear of childbirth. The objectives that we'd like to share with you today is that you'll be able to describe tocophobia, list the different classifications of tocophobia, explain the symptoms and the signs, discuss why there's a sudden surge of tocophobia happening in the 20s, discuss the treatment plan as well. So what exactly is tocophobia? Well, tocophobia is a pathological fear of pregnancy and can lead to avoidance of childbirth. It can be classified as primary or secondary. Now, in the primary, there's a morbid fear of childbirth in a woman who has previously no experience of pregnancy at all. In other words, her fears, her reflection of how birth is going to be is normally through storytelling, what she's heard from others, her imagination, what her impression about birth would be like. The second is the morbid fear of childbirth, which has developed from a traumatic birth experience from either her first or her second birth herself. So what is the actual incidence of tocophobia? A study which was conducted worldwide actually looked at the prevalence of tocophobia in pregnant women. And basically they saw that up to 14% of women actually have a fear of childbirth. Now, there has been some insight to the fact that it actually is getting more and more common. And some studies even say much higher levels, which we'll learn a little bit later. So if you look at the cycle here, you'll see that women approach birth with a very negative expectation, first of all. And then it moves on to the woman's natural birthing ability is inhibited by fear. Because when we're scared, there's overwhelming amount of adrenaline in the system, and that's called the fright and flight. And that actually takes away the oxytocin from the body, which is the hormone that actually helps women to go into labor and to contract the uterus from the receptors within the uterus. With that, women distrust or the birth itself, and they're accepting, and they suddenly start to accept this amount of intervention that's thrown on them. So no, I can't do it anymore. You take over, and then they allow the actual medical interventions to take over, feeling that they own the birth now. So women have a negative, high intervention experience from that. And these negative experiences are shared in the media and by word of mouth. And that is where the primary tocophobia comes into play, where women have heard stories about their bad birth experiences, whatever. And a lot of the time, what we're going to discuss in this presentation is it's often related to the intervention that happens within a hospital setting. So there was a study there that was also conducted, and they actually said up to 30% of women may actually suffer from tocophobia. Now that is nearly 1/3 of women who are pregnant are scared of birth. Now the logic that goes through to that is that why on earth would they have a vaginal birth? Why don't we just take the easy way out and have a cesarean section? I just have to lie there, let them remove the baby like a cyst or major abdominal surgery. It doesn't matter if I get my uterus cut in half or my body cut in half. At least I don't have to deal with it. However, there are many consequences and there are many disadvantages of a cesarean section, even though it is a life-saving surgery in cases when it is used properly. So the symptoms, the signs and symptoms related to tocophobia can be quite debilitating. I mean, thinking about it, just a pregnant woman, normally these women are incredibly excited, they're joyful, they have this intense, overwhelming feeling of being so special, and they are treated really special if you think about it. But people who suffer from tocophobia have physical symptoms as well as psychological symptoms. The sweating, they can even tremble, they have hot flushes or chills. They even go as far as having the shortness of the difficult to breathe. And this is because of the adrenaline, the fright and flight. It has an overwhelming effect on all the organs in the body from the catecholamines. They can have tachycardia, which is fast heart rate, even a choking sensation, pain or tightness of the chest, and a sensation of even butterflies in the stomach. Now, the psychological symptoms is women will have a fear of fainting or losing control, There's a sense of fear of dying that may even happen to the extreme, fear of that harm is going to happen to them or their baby. Excuse me. There might be some guilt, shame, or self-blame. And then, of course, they start to withdraw from others because they do feel that there's something wrong with them. They're not like their mothers who have given birth, or their mothers who have given birth, or their mothers' mothers who have given birth, and they are not normal. And how can they possibly go through this where life would not be existing without the history of how women have birthed for thousands and thousands of years? So there is a big thing that we call who's afraid of the big bad birth. And I think these stories come right from when we're children. And there is some historical empirical thought that goes along that when a woman gives birth, she doesn't really focus on the beauty of the birth experience, but she will always enhance what went wrong. I mean, I can talk about myself, for instance. My mother, I was the fourth baby, and the doctor induced me thinking I was overdue. And this is in 1967, so I've told you my age. And so those days, the ultrasound wasn't really good. And at the time of birth, even though I was the fourth baby, my mom started to bleed. And so they had to do some procedure and tie her legs up. It was absolutely awful, and use a suction to get me out. And this is how my mother projected the birth of me onto myself as such. And I could just imagine if I wasn't a midwife, I think I'd be absolutely horrified of giving birth. But if she'd spoken about the beauty of the pregnancy, I was her only daughter that she'd had, and all of that thing, my thought pattern would have very much changed. So we do have to remember something very important, and that is birth is not a medical circumstance. Birth is a safe passage for both mother and baby, and both are fully equipped for the journey. And that is the key. We are designed to give birth. We are designed to be born. Women are in a vulnerable state during labor, incredibly vulnerable. The most vulnerable state any woman could ever be is when they are actually in labor and are easily sabotaged in their plan for normal birthing. So looking at these areas, there's certain dynamics that are happening because of the vulnerability. They can be manipulated, they can be coerced into medical intervention that society would like us to like. We like to hurry up birth nowadays. It's almost like a factory, and we need to get things done quickly because other people are waiting, and it can be quite sad indeed. There are some possible reasonings for the surges of tocophobias in the 2020, and I'm going to hand this over to lovely Sawa, and she will now explain to you the essential physical resources which we should be having, the competence and the motivated staff versus the increased amount of interventions that may cause the tocophobia within the patient. So hand over to Sawa. Thank you.
Thank you, Tracy. Hi, everyone. So glad to join you all. Then, as Tracy said, there are some possible reasons for the increased surges in tocophobia that increased interventions also, such like, for example, we tend to induce women and we tend to have early admissions to hospital unnecessarily. Episiotomies have been always a fear for everyone. And yes, sadly, the rate is still high. And it's related also to operative vaginal deliveries. Women during labor and birth are always on intravenous injection. Is it really necessary? Should they be nail per mouth? Do they have to be on continuous monitoring? Do we have to question about having them having a cesarean section? And the most important one now, as you know, we're in 2020, COVID-19 restrictions. COVID have changed our life. We don't tend to see each other. We don't know to whom we are talking. We don't see their faces. People are not having their companion as before, so they don't get the support. All those are elements then that like lead to having the whole process change. So we moved in from the positive idea of having an essential physical resources to having limited decisions. The belief that birth is a dangerous process is simply unfounded and unsubstantiated. In fact, it's a tried and proven means of entering the world. Reason why some physicians perform the interventions and manipulate women into believing this is the only option. Technological interventions are available now to be used. The threat of malpractice suits as well. We have some economic incentives. Lack of trainings. Do we keep ourselves updated? Do we train ourselves continuously? The belief that a cesarean section is a superior option and the best option. And the old imprinted policy of once cesarean section, it's either always another cesarean section or there is a high chance for a second cesarean section. All those elements have played a very important role in changing the whole birth experience and making it like a fear of childbirth. On a case study, and it's a very interesting one, I've heard it and I've read it and it's really amazing. I was about 8 years old when I first realized it, sitting on the floor in my parents' room. My mother asked how many kids I wanted and I said 2, but I don't want to be pregnant. I remember an overwhelming feeling of fear, a pit in my stomach and anxiety, wrapping my body in cold waves. My mother laughed and said, every woman's go through it. It's a part of life. She went through it. Her mother went through it, and hers before. Things will change as soon as you grow. We always hear it. Women always hear it. They feel it. Are they supported for that? On a second story as well, my fear is around the pain, the needles, the whole experience. The thought of having to give birth to a baby, to me, is like a death of sentence. Isn't it? It's a nice one. Tocophobia can be a lot less debilitating when a strong support system, including partners. A study reported that 50% reduction in cesarean section birth rate when women receive psychological and prenatal support. This is an ideal treatment. And some of it comes in another forms like cognitive behavior therapy, psychotherapy, or talking therapy. Do we always listen to women as healthcare provider, as support system? Hypnobirthing techniques, home birth and water birth, simulation of nature and natural birth process, aromatherapy. Of course, last result would be medication prescription, but do we always go back to nature? Do we always simulate the normal vaginal birth or the normal birth process? That's going to be a relief. Trust. Do we still trust our physicians? Do we still trust our healthcare providers? Can we help women to gain that confidence again, to defeat the childbirth fear that they have? Do we help them to heal from tocophobia? It has been also reported that vaginal birth have been known to reduce anxiety and heal women from dread fears, such as women who have been sexually abused can feel healed after a vaginal birth. Previous negative birth experiences, as expressed by Tracy in the previous slides, can be healed by positive birth experience only. Some women have even suggested that sexual experience with partners after birth are enhanced and anxiety have disappeared. I would let you all look at this photo and think, the cave that you fear to enter holds the treasure that you seek. And that's exactly the fear that a woman have when it comes to tocophobia. Society has created this image around birth being dangerous as well. We as a society has impacted on this. Birth, as we know, is a natural and normal process. Beautiful birth stories are rarely told. Society will also discuss the worst event in childbirth. The promotion of a cesarean section does not help. A billboard in Los Angeles once stated, have a cesarean section and stay honeymoon fresh. Is this all what women want? If we look into also the cost of childbirth by country, it has been always reported that the cost of a cesarean section is most expensive. Even in the United States, it's around $16,000. Is that a cost that we want to take on our shoulders? Why don't we go back to nature and control our costs as well? I've loved this statement, and I wanted to share it with all of you. And that's a reflection for all of us, knowing that giving birth should be a greatest achievement, not a greatest fear. Birth is a significant life experience. Its effects are immeasurable and boundless. It needs to be and can be a time of peace, exhilaration, joy, and growth that can be treasured for a lifetime. As a conclusion, tocophobia can be debilitating and can destroy all idea of having a happy family. all accounts for approximately 14% of women of childbirthing age. Tocophobia is ideally treatable and can be managed effectively with the proper support. Who can be the support? Myself, you, all of us around today, and everyone. Women need us, they need our support, they need their friends, their family support. And that's the reason behind this presentation, to increase the awareness and empower women and lead and say, women have right to make their own decision. They have right to be supported. And we do have to contribute in that. And those are our references. Thank you very much, and it was a pleasure to be with you.
And Salwa for a very, very informative talk on tocophobia. Now, second time lucky, we're back to Khawla Barley after the initial technical error. So the next lecture, which is the first one originally, is by Khawla Barley. So I'm going to reintroduce Khawla. Khawla has drawn upon her background in management and experience in teaching to passionately deliver inclusive recreational programming for individuals with intellectual disabilities and autism throughout the UAE. In 2014, she founded Goals UAE, a community-based initiative which pioneered the implementation of sustainable recreational programming for children with autism within the UAE. In her current role at Special Olympics UAE, Khawla continues to expand opportunities for the growth of individuals with autism and intellectual disabilities through the establishment of programs like Unified Robotics, which is the first nationwide program promoting inclusion of POD within STEM in the region. Through community collaboration and family engagement, Khawla advocates for the establishment of recreational and vocational opportunities for individuals with intellectual disabilities and autism across sports, art, and STEM. Khawla is going to be talking about virtual unified sports model, promoting social connection for individuals with intellectual disabilities and autism during the COVID pandemic. So really, without further ado, over to you, Khawla. Thank you very much.
Hello, good afternoon. Thank you very much for joining me today. My name is Khawla Barley, and I'm the Initiatives Development Supervisor with Special Olympics UAE. And today I'm really excited to share with you the work that we have been doing during COVID-19 and what we've learned. So today I want to present to you our virtual unified sports model, promoting social connection for individuals with intellectual disabilities and autism during the COVID-19 pandemic. So when COVID hit in late spring, well, it didn't hit in late spring, but when all of the restrictions hit us all, and we found ourselves working from home, our kids were going to school from home, everything was shut down, right? No more sports practice, no more parties, no more, no more anything, right? So this had an incredible impact on everyone. We were all taken by surprise. And at Special Olympics, we were especially concerned because the population of athletes that we work with, those with intellectual disabilities and autism, experience social isolation and mental health problems at a much higher rate than the general population during the best of times. So obviously, we were very concerned about what was going to happen when different activities and social channels were cut off. So in the best of times, we know that individuals with intellectual disabilities can have up to 50% of the population of individuals with intellectual disability can be identified as socially isolated. And that is in contrast to about 15 to 30% of the general population. Now, individuals with autism have some of the highest rates of social isolation and depression amongst various disabilities. And one of the studies that I have cited in the references of this presentation is a study on young adults with autism, on the autism spectrum. that were found to have the highest rates of social isolation amongst individuals with intellectual disabilities, various learning disabilities, and autism spectrum disorder. And individuals on the autism spectrum were found to be 28% of young adults studied were identified as socially isolated. And that meant that they identified that they never saw friends, that they never received phone calls from friends, and that they never were invited to social gatherings. So they never had a friend call up and say, let's go to the movie. 28%. Now, that is alarming, and that is in the best of times. So what was going to happen in COVID-19? And anecdotally, we knew from families that there were negative impacts from day one. And so we were concerned, and along with our partners at New York University, we launched the Virtual Unified Partnership Program in May of 2020. And the main objective of this program was to decrease social isolation of participants. Now, what did we do? What we did was we utilized the Special Olympic Unified Sports Model to bring together athletes with intellectual disabilities and autism with their typically developing peers, who are termed unified partners. So together, athletes and unified partners work together on a team. Now, in the case of the Unified Partnership Program, we elected to have unified pairs. So we wanted to just match up two individuals to focus on the social connection. And for 6 weeks, from May 2020 to June of 2020, 15 NYU AD student athletes trained twice weekly via Zoom with 16 Special Olympic athletes that were diagnosed with intellectual disability or autism. And the objective was to recreate the unified sports model virtually and to battle the social isolation and negative and the mental health issues that were associated and being faced at home. So unified partners and family members completed pre and post program surveys in which we were looking to gain insight into their attitudes and beliefs about people of determination. In the case of the unified partners, and in the case of families, we were looking at their attitudes towards establishing connections online, and as well as the impact on their feelings of social isolation. So we also, in addition to family interviews, we also conducted weekly student meetings in which we were able to not only provide support, but also to gather data from the students. Okay, so the unified sports model that we were looking to recreate, again, as I mentioned, the unified sports model is at the heart of Special Olympic programming. And what it does is bring together individuals with intellectual disabilities and autism with their typically developing peers on the same team. They're focused on something positive. What we find is that everyone's abilities are highlighted and their disabilities or challenges sort of fade into the background. So very quickly, in a nutshell, in mainstream society, in the community, we often find things are segregated, special programs for people with intellectual disabilities, special schools, and then you have mainstream schools and mainstream programs. Some negative attitudes based mainly on a lack of understanding, and most importantly, very low expectations. And this also extends to families. People feel that individuals with intellectual disabilities need to be cared for. They may not be able to, accomplish as much in life, and they need to be cared for and protected. So these are barriers to social inclusion. And what we find within unified sports is when you bring individuals together, you focus on what they can do, they're working together on teams, you're gaining understanding, breaking down barriers, and you're paving the way to friendships and relationships. So the focus is on personal development, meaningful engagement, as we call it in Special Olympics, inclusive and equal bonds. So people are brought together as equals. It's not a charity event. It's not a volunteering event where we're going to help individuals with intellectual disabilities. This is about bringing people together as peers and positive representation. As I said, when you're bringing people together on the same team, the focus is on what everyone can do. It's not on what they cannot do. So this is what we're trying to recreate. This is what we know works on the ground. We know that the unified model works. Some of the key findings from research that has been done in the United States. Again, Special Olympics is new here in the UAE, so we're just beginning our impact studies. But in the United States, where there has been much research done on unified sports, it's found that 82% of family members reported that athletes improved their self-esteem, their self-confidence after participating in unified sports. 94% of athletes and teammates, so that's unified partners and athletes, said that unified sports made them healthier. 91% felt that it improved their sports skills. 79% of participants, of unified partners, in a unified football program reported that their understanding of people with intellectual disabilities improved. So again, we know that the unified model works on the ground. What we wanted to know is if it could be adopted into the virtual sphere. Could we have the same or similar results? So our program, again, brought together NYU AD student athletes with Special Olympic athletes. Prior to the program launch, the Unified Partners went through 2 training experiences, one conducted by NYU, that was a minor safeguarding program, and the second conducted by Special Olympics UAE, which was a basic training that we do for coaches and volunteers on communication strategies for individuals with disabilities. And they were then put in pairs. They were matched up with an athlete, and they began the process of getting to know them and working together. So generally the first session was sort of a get to know you, and that sometimes involved a caregiver as well. So it was either the athletes and the unified partner, just the 2 of them, or the athlete and the unified partner and a caregiver. And what the purpose of that was to get to know them and get to know their fitness goals. Because in the case of this program, it was very individualized. And unified partners helped create fitness programs to meet the goals of the athletes. So first session was get to know you. They had to get to know the athletes' goals. They needed to know what, if they participated in sports, what were their objectives. And then over a 6-week period, a minimum of 12 training sessions were held with these unified pairs. And as part of the program, as I mentioned, we had weekly unified partner meetings in which we were able to give support, as well as a place for the unified partners to report. They reported to us weekly. All right, and here are just a few photos I wanted to share with you. So from the very beginning, anecdotally, we knew that things were off to a great start because the reports we were getting from both the athletes and the NYU students was that they were getting to know each other. So I, as an example, I have known some of the Special Olympic athletes for up to 6 years. And the unified partners, in a matter of a few weeks, knew things about the athletes that I had not learned in 6 years. So it was incredibly exciting to see that happening, right away. Okay, sorry about that. So what we did find, that was the anecdotal, you know, the smiles and the happy reports that we were getting every week. But then we had to look at the actual surveys, right? And the Unified Partner Survey really focused on two areas. One, the comfort level engaging with people with intellectual disabilities and autism, and their beliefs about the abilities. And now families, we were looking at their beliefs about their loved ones' abilities to engage online, and specifically also their ability to develop and maintain friendships. All right, so comfort level, the Unified Partners questions that we asked to identify their comfort level engaging with people of determination was, did they feel comfortable speaking with POD? Would they feel comfortable with POD as classmates? Would they feel comfortable working alongside POD in a workspace, in their place of employment? Would they feel comfortable alongside people of determination in sports and recreation program? And would they feel comfortable with a person of determination joining their friends on a social outing? So we can see across the board a positive impact after spending 6 weeks getting to know people with intellectual disabilities. There was a positive impact on their comfort level. In terms of their beliefs, their beliefs about the perceived abilities of individuals with intellectual disabilities, did they feel they could live independently as adults? Did they feel POD would be successful in the workforce? Did they feel POD could manage their healthcare independently? Could they have successful marriages? Can they engage in mainstream sports and recreation? Or would they be most successful in environments tailored to people with disabilities? And also, could they easily master technology? And again, across the board, we saw a really positive impact. We saw that at the end of the program, our Unified Partners perceived the abilities of the POD to be much higher than they had in the beginning, before the program. And I think it's interesting to see there's a very large increase in their perceived abilities on mastering technology, because obviously they had just spent 6 weeks watching POD master technology. I also think it's very interesting to note the perceived ability for POD to work. That has an incredibly significant impact on, you know, vocational programming and employment programming. That is such a big focus today, and has such a big impact on the mental health of individuals. Being unemployed and underemployed is obviously has a very negative impact on mental health. Okay, switching to families. Their beliefs about their loved one's ability to engage online. Were they comfortable engaging with others online? Did they feel that online fitness programs would be as effective as in person? Did they feel skills could be learned online? Did they feel coaching could be as effective online? Did they feel friendships could be established online? And did they feel friendships could be maintained online? And as you can see, going into the program, families were neutral at best. And in most cases, they were quite negative. They didn't feel that the fitness programs were not going to work, and they were not going to be able to make friends. So they were, I mean, I'm really grateful that they actually went ahead and allowed the athletes to join, because obviously they had a pretty, negative perception about what was going to happen. But luckily, after the program or during the program, they obviously began to see a positive impact. And post-program, they were fairly positive, neutral to positive about everything. With coaching being, they're still feeling that coaching is not as effective online, but I think that's maybe a fair assessment. Most importantly, an incredible difference in their perception of their loved one's ability to make friends online, to engage socially online. Went from a negative 42 to positive 46. So that's a huge increase. And that is honestly the most important thing. We saw anecdotally from the reporting of the athletes and the unified partners and their smiles that they were socially connecting. This was reinforced by the families reporting as well. So that was an incredibly, important component for us and piece of information for us to gain. So what does this all mean? What we understand is during COVID-19 pandemic, social distancing implemented across the UAE and many parts of the world really brought about this deluge of online fitness videos, online competition, online webinars, you name it, you could find it online. But particularly when you're looking back at April, May, June, even into July, the majority of the content there lacked social connection. People were throwing things out to kind of keep you busy. And you'd find fitness programs that had 1,000 people logged in. It was, in a lot of cases, pre-recorded. So there was no social interaction. What we demonstrated is that didn't have to be, that we could use the virtual sphere to effectively implement the unified sports model and produce effective outcomes, to produce, social connections. So we showed that we were able to decrease the feelings of social isolation and have positive social connections for individuals with intellectual disabilities and autism. And that is an incredibly important bit of information for us as an organization, as Special Olympics, and as a community. Because what we now have is an additional tool. We now know that what we do on the ground and the positive impact that has, we can now implement these programs virtually and have also positive impacts. So what we see as a program is, and what we have done as a program, is to take the information that we've learned from this model, which was the first program that we ran, which is why we spent so much time trying to assess it. And we have implemented a number of programs. And we will continue to utilize virtual platforms and virtual connections to help increase the impact of our programming, even as we go back on the ground. So really quickly, I just wanted to share with you a few of the programs that we have done as a result. And two I'm going to highlight here that I'm super proud of. If you see in the upper left-hand corner, you see one of our athletes who is painting a palm frond. This is part of a program that we ran with about 54 athletes and their families, their siblings and their families and friends in the home. We worked with Emirati artist Azza Al-Kabasi, and everyone that participated received materials in their home. We all connected online in various small groups. It was, really fun and very social, very social. And we painted together and we talked about what we wanted to represent about ourselves in these palm fronds, because each of these palm fronds has now been crafted together into a public work of art that will be installed in a public space this week and on display for everyone to come and get to know our athletes a little bit better through their artwork. And that was created virtually. Another program that I'm really proud of that was run through our health department was something called Soul Gardening. And this program worked virtually to walk our athletes through growing herbs at home. So creating little kitchen gardens. And the focus was on mindfulness and connecting not only to the plants and tending to the plants, but also to using these plants in cooking and connecting to their cooking. So this again was all done virtually, and the impact has been really incredible. And again, Unified Robotics is a program that we run every year that has been adapted into the virtual sphere. And what we are seeing is that our ability to utilize the virtual sphere has increased our reach. We are seeing schools in more remote areas, families in more remote areas connecting to this program in greater numbers than we saw in previous years. Because the obstacles of transportation and timing are removed. So these are some of the tangible, impact of the work that we did and the data that we gathered through the Virtual Unified Partnership Program. So we're very excited about actually putting this into practice. Thank you so much for your time. I could have talked a lot more about this. It was a very exciting project, and we're still really reaping the benefits of what we learned from this program. So it's something that was incredibly rewarding for me to take part in, and I thank you all for listening. And please, I have listed my contact email and phone number. Anybody who wants more information about Special Olympics programming, about the data that we've collected, or anyone that has an interest in partnering with Special Olympics on research projects, please feel free to reach out. We are, again, really looking to utilize data to create the most effective programs that we can to have the widest and greatest impact within the community. And we would really welcome our community partners to join us on that journey. So thank you very much and enjoy the rest of the conference.
Okay, thank you very much. Once again, big thanks to Kaula for a very interesting talk. Now, it's my pleasure to introduce you all to Dr. Bruce Clark, who is familiar to many people within the region. Being the humble man he is, Dr. Bruce has asked me to keep his bio short, but I think it's very important to highlight Dr. Bruce's contribution to CAM services. He's a clinical director at Maudsley Hospital in the UK, and he is an expert in OCD and body dysmorphic disorder, and leads the specialist services at Maudsley Hospital there. He's also honorary research at the Institute of Psychiatry, Psychology and Neuroscience. And also, I think it would be amiss of me to mention that Dr. Clark was actually involved in the conception and opening of Maudsley Health Service in Abu Dhabi, and is one of the visiting specialists since the clinic opened. So he's got considerable expertise in assessment and management of autism disorders, OCD, BDD, ADHD, and so on. Today, Dr. Bruce Clark is going to be talking to us about updates in obsessive compulsive disorders. So over to you, Dr. Bruce. Thank you very much.
Thank you very much, Deepak. I'm blushing, and people can see my slide. As I mentioned earlier to people who are listening, I'm really, really fond of my time and relationships with the UAE. Also really inspired actually to follow that presentation about the Special Olympics. Really powerful stuff, really affecting. So I've spoken before at these conferences in the UAE, and I, as you said, lead the National Specialist Service for OCD and related difficulties. That's OCD and BDD is the majority of cases that we see. And so what I've decided to do today is pick up questions that I've been asked in the past when I've given talks. And so one of the things that I'm going to talk about, you'll see, is considering OCD in an ASD population. I get asked a lot about that in the UK, but I also have been asked about just touching upon some of those themes and teasing apart those issues when I've spoken to colleagues in Abu Dhabi and of course in Dubai. Now, I'm also going to talk about something called olfactory reference disorder or olfactory reference syndrome. I wouldn't be surprised if the majority of you have sort of never heard of that in your past careers. It certainly came to me later on in my career, and my understanding of that only really developed whilst working in a really specialist national service. But I want to talk to you about that just to highlight that perhaps it's not as rare as we might have thought, and I'm certainly seeing a good run on those cases. I feel very passionately about body dysmorphic disorder. I appreciate we have a really mixed audience from internationally, but also in terms of the types of clinicians, teachers, social workers from a breadth of different areas of practice. I am a child and adolescent psychiatrist, and body dysmorphic disorder and issues with body image are very important, I think, particularly when thinking about young people and their development and their sense and the impact of body image issues. So now a slide filled with looks like a lot of data. I wanted to just highlight that both ICD-11, the World Health Organization's manual, as well as DSM, have changed the way that OCD has been categorized. I apologize if some of you know this already, but the change was in both systems, the same thing has happened, and obsessive compulsive disorder was lifted out of the group of anxiety disorders and placed into a new category and chapter called obsessive compulsive and related disorders. Nobody was trying to pretend at all that these young people or adults do not have anxiety, but what research seems to be showing is that this group of disorders that I've listed on the screen have more in common, and the thing that they most have in common is repetitive and compulsive behaviors. And so there you see it in the middle is olfactory reference disorder, which I'm going to mention a little bit about later. So on to the first topic I said I'd cover, and people have asked me about a lot, is how do you tease apart and what is the relationship between OCD and ASD? So here we go, just a few thoughts. So studies have varied actually. When you look at a population of people on the autism spectrum, we know that mental health difficulties for a variety of reasons are much more common than in the general population. My close working colleague, Professor Emily Simonoff, I was asking her recently, what paper most inspires you from all your body of research? And she explained that for her, a paper that she published just highlighting how common anxiety disorders were in a properly researched group of people with autism was important because it drove home the impact of these difficulties. Anxiety disorders are extremely common. In fact, her data in her population, she was able to show that 60% of people on the autism spectrum have an impairing anxiety disorder. And amongst those anxiety disorders is OCD. So already we know that people with ASD are prone to anxiety, and it seems that people with ASD are particularly prone to developing obsessive compulsive disorder. And perhaps that will become a little bit more apparent in the relationship later as we talk about it. But those of you who are familiar with OCD or indeed ASD will be aware that there are similarities. If we think about a population with autism, one of the defining characteristics of autism spectrum, if you like, is this tendency to repetitive thoughts and behaviors. Does that sound familiar? It does a little bit to me in my clinic because it sounds a little bit like compulsions in the patients that I see with OCD. And in fact, just as I've highlighted, this population of folks on the autism spectrum are very prone to developing OCD as one of their mental health difficulties. I work in the UK's only national referral centre for children with really challenging OCD. And in our clinic now, 1/3 of the patients who are sent on for us to look at have this combination. They're on the autism spectrum and they have OCD. So disentangling these two things, I'm not going to pretend it's always super easy, but I would say actually with experience and in clinical hands, it's usually slightly easier than you imagine. So let's just have a think about that. And this slide I've entitled Repetitive Thoughts, and we're going to just have a think about OCD and ASD and just have a think about how they might be similar and how they might be different. If you're looking at OCD on the left hand of those two columns, we might call those repetitive, or should call those repetitive thoughts, obsessions. And key themes are common. Wherever you look in the world, wherever you practice, the key themes of obsessions are contamination, harm, sexual intrusion or violent, which are often referred to as forbidden thoughts, and things called just right obsessions. Whereas in ASD, the repetitive thoughts, the things that may, if you like, preoccupy, being a repetitive stereotyped interest, are much more diverse and often include and can include some quite stereotyped, interesting interests. I remember a young person I met recently, his special interest was mustaches. It's not very often that you meet young kids whose special hobby is mustaches, but it was his specialist interest. Now, the important point, if we look at the next line around distress, on the left-hand side, you've got to, if you're thinking, are these features that I'm seeing, are they part of OCD? You have to go and look for, are they causing distress and unpleasantness, or so-called ego dystonia? The person wants to get rid of them. And in OCD, you typically find that that is the case, and that those thoughts, the person will tell you, is causing impairment, it's getting in the way. Whereas in the autism spectrum group, their special interests and the things that they repetitively think about sometimes can irritate them. Like they say, sometimes, it's just getting a bit too much. But almost always, they will tell you that a lot of the time it doesn't, or it hasn't in the past. And I really sometimes engage with them. It's pleasure to me. And there can be a clear overlap. It's not always easy to tease them apart, but obsessions are in essence distressing and anxiety provoking, whereas the specialist interests within ASD are typically and often not so. If we then move on to untangling repetitive behaviors, in OCD, we refer to those as compulsions or compulsive rituals, if you can watch them, or compulsive mental rituals, if they're just happening inside a person's head. The content of those very often matches the obsession, so washing for contamination fears, etc. Whereas in ASD, you again see a much wider range of repetitive behaviors. And there often isn't such a clear relationship to thoughts. So in younger kids and kids perhaps with greater levels of developmental disability in autism can engage when they're younger or more impaired in some of the repetitive behaviors, such physical behaviors such as flapping and rocking. And those sorts of things can be seen in OCD, but they look very different. Ordinarily, they look very different. Once again, it's important to highlight that by definition in OCD, these rituals or compulsions are distressing and unpleasant for the person, but they feel compelled to do it. They find it hard to limit it, and they continue to grow. Whereas the opposite is very often the case in ASD, that it's pleasant, they do it to decrease their levels of distress, they might choose to spend more time in doing that. And another thing to have a think about is just considering, when did these behaviors start? So OCD, it's rare to see OCD before the ages of 7 to 12 years in somebody, whereas of course with an autism spectrum, the history will indicate that repetitive thoughts and repetitive behaviors have been present throughout life, and certainly from very early on in development. And when I'm talking about taking histories in ASD, when I'm teaching people from undergraduates right through to postgraduates, I always say for OCD, and the same would be true for ASD, it is of course vital that you take a comprehensive and thorough history. I always remind people when assessing OCD, you might think about OCD as obsessions around dirt and contamination with compulsions that include washing and rituals to alleviate that. But you must dig further. You do not meet people who have OCD and just one obsession. I can't remember the time in the last many years of seeing a person who has a sole obsession and associated compulsions. And that's really helpful. If you're struggling to disentangle OCD and ASD, taking that really comprehensive history will show you other things which are clearly obsessions with associated compulsions. So taking that comprehensive history can make you much clearer that we've got both things going on here, or this looks much more like OCD or much more like someone with ASD. And I hope that makes sense. So moving on to thinking about, well, how do you and how can you treat and support these individuals who present in childhood or adulthood with the combination of OCD and ASD? Well, in essence, the message is the same as for people with OCD who do not have ASD. The evidence base has been really quite extensively researched since the early part of this millennium. From 2000 onwards, there have been case studies. We carried out a randomized controlled trial in our study. And there have also been many non-randomized studies looking at the outcomes of CBT. And the evidence is quite clear that people do respond to treatment for OCD when they have ASD, but their rates of response, i.e. showing improvements, and their rates of remission, whereby they get rid of OCD altogether, are lower than people who just have OCD alone. That's no surprise, I would have thought, to any of the listeners. Now, this paper came out of our team some years ago, and we were keen because, you know, we were showing in our OCD population, folks who just have OCD, that we could get up to 80% of them better. 80% after treatment could be reporting that they no longer registered as having OCD. And we were really keen to move that forward and say, can we get better? And just in short, we've done a lot of research to refine and develop a treatment manual. It's a visually led treatment manual with a practitioner manual to sit alongside it. And by using this manualized approach and looking at our data, we've dramatically improved the rates of response and remission. We're now seeing rates of remission in treatment of more than 40%. It's not as good as OCD on its own, but it's dramatically better than it was before. And we're continuing to look at this area and make further developments so that hopefully people who are on the spectrum will get the same kinds of responses that someone without autism in addition to OCD can expect. Now, moving on, what about this mysterious syndrome of olfactory reference syndrome, or as ICD-11 calls it, olfactory reference disorder? Everything in ICD has to have the word disorder on because you have to prove that this is having a disorder. Well, I said earlier, most of you won't know what this is, I'm imagining. It's a type of OCD, and you know what? It's actually not hard to find if you go looking for it. And we have seen a real run of young people where this is their type of OCD. And the reason it seems to be different is the focus is really narrow and focused on this fear, obsessional belief that there is an offensive odor emanating from the person. And their experience isn't that of, you know, I just have ordinary everyday body odor. It is much more extreme. And we call it of delusional intensity. I met a young person earlier this week whose olfactory reference syndrome, she was convinced as a product of how strong her smell was that people in her class were hiding the fact that they were vomiting because they were so overwhelmed by the smell. And she was also convinced that there was something wrong with her armpits and that she was sweating much more profusely than anyone else would, and that you could smell this for long, long distances. So a cardinal feature of this disorder, or this type of OCD, is that it is quite narrow in focus and that insight is typically poor or absent. I would say of the cases that I've seen, and we're writing up a case summary, just about every single one of them, their beliefs about their odor are of delusional intensity. There is no persuading these people that, in fact, their views about how much they smell are not in keeping with how other people would see them. And efforts to say, look, you don't smell, get you nowhere therapeutically. So what does research show about how you do approach these patients? The graphs that I have on the bottom right there are from Google Trends, just looking at the numbers of papers published per week in the areas. The red line is OCD. The yellow line is body dysmorphic disorder, and the blue line, which basically is hanging on 0, shows that really there are next to no publications coming out in this disorder, and we are certainly seeing people coming through the clinic. So if you're working and practicing clinically, just keep an eye out for this. The practice, and we are largely led by practice rather than research in this area, is to try SSRI medications and modified forms of CBT. There are descriptions in the literature of using EMDR, but they're single case reports only. And generally, the psychological therapy draws a lot from the model of body dysmorphic disorder, where also typically the beliefs about appearance in BDD are also of delusional intensity. And the important thing is adapting, and we're trying to use some of the models that we use to shift very fixed cognitions that we use for BDD, and we're trying to apply those and research their impact in olfactory reference disorder. The one thing I just wanted to emphasize to my colleagues who prescribe is there is no evidence and no clinical view that antipsychotic medications should be given to these patients. That's the same for BDD. There just is not the evidence that you will make any difference in these delusional intensity beliefs with antipsychotic medications. If you're using a medication, I would commend you to only use an SSRI. And in the case of body dysmorphic disorder, the research evidence to support that statement is strong. Those kids and adults will not respond to image-related concerns by offering antipsychotic medication. They will respond to SSRI medication. So just some quick reflections before we talk about body dysmorphic disorder. We've seen in our clinical experience that the anxiety levels in this population, these are not adolescents who think, oh, I get a bit smelly after gym and I don't wash my gym gear. It's at a whole different level. And I described a case example, which could be very typical of the extreme. There is a sense that this becomes prominent after puberty, and a sense that sits with that careful psychoeducation is important, that indeed our bodies do change at puberty, and that smells and other sorts of changes happen then that need to be considered. But the belief systems that these people have that sit around that go way beyond typical adolescence and experience of puberty. We've learned that anxiety on doing exposure work with these young people can be extremely high. And we're carefully learning how we plan those exposure tasks so that we can plan a sort of typical therapeutic session with an exposure task that will show anxiety coming down in a reasonable time. And we're gaining experience at doing that. And we're also learning that, as I mentioned earlier, we are drawing on models from the area of body dysmorphic disorder to work on the way we have become accustomed to helping use a more cognitively led model to shift very fixed views about, in this case, body odor. So rather than being behaviorally led, we typically use a model that is more cognitively led in psychological therapy. I don't have time to go into that in more detail, unfortunately. So what about body dysmorphic disorder? Just to remind people, this is again a type of OCD where the obsession, the repeated unpleasant intrusive thoughts are about appearance, disliking appearance, and the compulsions are extreme and disordering. They include checking, mirror gazing, seeking reassurance, checking out cosmetic surgeries, thousands of selfies a day, in my clinic avoiding going to school, not going out. And again, 50% of these patients very typically have delusional intensity beliefs, saying things like, my skin is battleship gray, I have two noses, my nose is 80% of the front of my face. So not everyday adolescent or experiences of image concerns. We all have image concerns, but they're not disordering. So disordering means, of course, that these image concerns are having an onward impact in your occupational, your family life, or for young people in their school life. And when you look in the past, or when people have looked, people have guessed at around 2% of the population have BDD at any time. It's always important to reflect, I think, in this entire area of practice that OCD, all of the OCD, it's twice as common as schizophrenia in our populations. And yet our mental health services have a very small number of these cases. These cases are suffering quietly and sadly in our communities and not coming forward for a range of reasons, thinking they're vain, feeling a tremendous level of shame. And it's really important, and that's why I always talk about this, because I want people to start asking their patients, and I'll emphasize that point later. People often ask me, what is the prevalence in young people? And here I've shown the previous studies have shown that indeed in that younger age group, BDD at a disordering level is commoner than it is in people who are a bit older. But we mustn't forget that BDD is a very pernicious and disabling condition, even in adults. What we know from epidemiology is that where BDD is present, it very typically has started in childhood, usually in late adolescence, but it's not at all uncommon to start pre-pubertally. And yet research and awareness in this area has really lagged both adult mental health and other areas of mental health research. Now, what are the key things we need to keep in mind? Insight, as I've already highlighted, is ordinarily poor. I've got a large adult up there on the left and a child with data on the right, but the message is insight is poor in young people, 50 or more % delusional, and no way you can convince the person otherwise about their appearance without a therapeutic intervention. But this next two lines, if you like, are the one thing I want you to remember if you're in clinical practice, to not forget to ask about this. The rates of suicide attempts are dramatic in BDD. Up to 80% of kids who have BDD and keep it lifelong will up to 80% will make an attempt on their life, and up to 50% of BDD patients at any time have suicidal thoughts. We are just doing some research at the moment where we screened in the community for people with BDD and got folks who'd never, ever had any therapeutic input from a service. And in that group, they'd never met a mental health clinician. 30% in our screening had already made a suicide attempt and had not come into services at all. Now, I presented data that was a little bit old earlier about the prevalence, and we were quite proud that we managed to get a BDD screening into the mental health epidemiological survey in the UK. This is the largest epidemiological survey of children's mental health in the world, and it's repeated every 10 years. Well, what did it find? That's one of the key messages. It's the largest ever sample. They do a very sophisticated sampling across the UK. They were able to identify up to 900 people with BDD. And in essence, what they showed was kind of similar, but the one takeaway from this slide, alarmingly, is that the study showed that just shy of 6% of females in the 17 to 19 group met the BDD criteria. That's quite a shocking statistic, and underpins and perhaps should sit alongside our efforts where we are seeing people who've made self-harm attempts or suicide attempts to remind ourselves to ask about appearance concerns. A simple question on screening, such as, do you have any significant worries about your appearance, is all you need to do to open up the conversation. And research shows that a simple question like that will lead you very quickly and easily to identifying BDD. The diagnosis is not difficult to make. The study that I've alluded to is a huge one, and we'll have more data to come, and we're working hard on that with partners. We've been working hard as a clinic, really pushing this message. Don't forget about BDD. It's a big issue. There's lots of interest in the media about social media and its impact on young people's self-perception and body image. We published this book, Appearance Anxiety. It came out. It's the first book aimed at young people. It's a sort of guide for young people, their families and professionals. It's been very well received, and it's the first one of its type. And just our efforts really at this moment are to raise awareness. Now, I showed this video, I'm not showing it again, but I've put the reference. You just need to go onto Vimeo and search for Because I'm Ugly. We worked on this with the BDD Foundation, which is a charity in the UK. So the video is called Because I'm Ugly. I showed it to people at the last Maudsley Health Conference, and you might be interested to look at that. It's a very compelling and beautifully scripted cartoon video talking about BDD. Young people in our experience with BDD are finding it very helpful and supportive. Just a quick word about treatment outcomes before I finish. We've been working really hard. We carried out the first randomized control trial of treating young people for BDD in our clinic using cognitive behavioral therapy. And the reason that this slide is important, we've been following up that group. And not only that, we've been pooling data now with other countries. And we published a paper in the Journal of the American Academy following up across multiple sites internationally, the largest cohort of BDD patients. And actually what we showed was very encouraging, that at the end of treatment for a condition that previously was felt to be untreatable, look at those stats. At the end of treatment, 78% of people had responded, i.e. shown some improvement, and nearly 60% remitted. And so the refinements that we've made to our treatment have been really good. And lo and behold, after you stop treatment and follow people up for 12 months additionally, it's really encouraging to see that those gains are maintained, that 83% of folks have responded and 68% no longer would record having BDD for some something that I know to be driving high levels of suicidal behavior. We're writing up the treatment manual that we've been working on, and it's coming out, and it's a tight and manualized protocol. And again, Sabina Wilhelm and the team at Harvard have a really brilliant book on CBT for BDD, but this is the first I beg your pardon, parent guide for body dysmorphic disorder. So that the image there is the parent guide. We've published that, and we're also publishing our own manual for treatment, but that's still to come. So what about social media? I'm not going to talk about this a lot. It's obviously something that people ask about a lot, and we are doing good research to kind of examine this question. But just to say, where there are worrying types of social media use that do concern parents, they concern me, we mustn't lose sight of social media is not going away. It is an ingrained part of our society's lives now, and we must not forget that social media and other internet options are also extremely positive in many instances, and understanding the balance and teaching and training young people around safe use of the internet is, I think, the best way to summarize the state of the art without presenting more detail on what sits behind that. I have to thank my colleagues. My team in London are up there on the top left, and colleagues that we work with and do a lot of co-work, including one of my team who's over in Sweden. No, two of my team are in Sweden on the other side of that slide. So just to thank those people, because we do a lot of really great collaborations together. And I'm proud to put up my thank you slide. And this is a bit of a, I think most of the people in our department haven't seen this. This is the new building that we're going to be moving to, the Children's Mental Health building at the Maudsley Hospital in London. We just got planning permission at the beginning of last week to go ahead and start building this. So it's very exciting times to share that with you, a little piece of news. So thank you very much.
Right, so we're going to go into the Q&A session now. So if I perhaps start with the first talk, Tocophobia, by Dr. Tracy Roke and Salowa. A couple of questions, really. That's I think one of the questions was in terms of the numbers of the numbers of prevalence of tocophobia in the UAE, and how does that compare with the numbers in other. Thank you very much, Dr. Bruce Clark, for an excellent and informative talk as always. I was actually personally quite fascinated by the new build and the building permission you're going to get. So I think it's exciting times ahead. Okay, what I'm going to do is I'm going to go back to the first speaker, Dr. Tracy and Salowa, talking about tocophobia. A few questions. So one question that came in really was looking at numbers, so really prevalence of tocophobia in the UAE, and how does that compare with kind of global prevalences? So any comments on that, Dr. Tracy?
Well, I can add to that in the sense that when I was actually giving the discussion, I was thinking to myself about the fact that perhaps us at the hospital setting could actually do a study and actually look into it a little bit deeper. We did do our research, and literature review didn't really cover things that related to the UAE. And I think it might be, this is just my perception, because the local women, as I know, I've been in this country for very, very long, like 15 years now, have got the strength, a characteristic about them when they give birth. There's a unique strength, and it's really beautiful when you watch women give birth. And I think for them to really admit the fact that they are scared of giving birth could be a little bit taboo. So that's a good question in the sense that maybe it would be a recommendation for further research, that we could look deeper into this with all the hospitals around and do maybe a huge cohort, multi-centered cohort research.
Absolutely. So I think there's always research that can be done. So, okay, thank you for that. I was quite intrigued. I mean, one of your slides made reference to the fact about cesarean section and with a stress-free kind of journey and so on. I mean, is there any evidence that the numbers of cesarean sections are going up as a result of tocophobia?
I do believe that, yes, indirectly, and I do believe that the healthcare practitioners often use this as an excuse. Women will go and see the doctors and they will explain or express their fears, and it's a very good, easy loop just to get in there and say, well, why don't you rather have a cesarean section? I mean, we do know in this country, Department of Health is very adamant in reducing cesarean sections, and we all have to do various groups and things to try and see what we can do to actually put in place to help reduce it. And this is one thing that is a very big need. Women are, as we said in the presentation, incredibly vulnerable, not only in labor, but also in the pregnancy state. And they hugely rely on what the healthcare provider says. They search on Google all the time, they do that, but at the end of the day, they'll still go back to their physician or their midwife and rely on what they've said. They often don't question. So cesarean sections are absolutely on the increase, and this is why in the 2000s, the tocophobia has increased over the years. I mean, from 14%, which is a very big randomized trial, right to 30%. So 1/3 of women, are requiring intervention or cesarean sections because of fear. So absolutely.
Okay, I mean, I guess what you're saying is, I think they can be quite influenced by what is being said out in the media, what is being said by their kind of primary physician and so on. So is there anything in the cesarean section world to talk about, whether people actually have tocophobia? Is that something that's being recorded statistically anywhere?
Yes, when we were doing some research on it, there is quite a lot of groups out there that do talk about this great fear, and that leads on to cesarean sections. And these groups are out there to support women, antenatally, even, preconception phase, even as young as puberty, to actually help them realize that all they need, people often we actually excluded, they need help. They just need support, they need love. As I said, good storytelling, emotional support, even as a very young stage, even before even considering pregnancies. I think we've just been so illuminated to all these horror stories that we just can't, conceive giving birth.
Okay, thank you, Tracy. Last question is, does tocophobia improve in subsequent pregnancies?
Maybe I can share this question with Salwa. Salwa?
Yes, Dr. Tracy.
So the question is, does tocophobia improve in subsequent pregnancies?
Well, to be honest, we share it in our slides that previous negative birth affect normally, but sharing, as Dr. Tracy said, the positive experience for birth can improve also the treatment of tocophobia. And I think that's one of the things that we're working on together. It's just like sharing more positive birth experiences with our women, especially in the Gulf countries, not only in UAE. And that leads to a positive feedback from patients to reduce the fear of childbirth or tocophobia.
Excellent, excellent. Okay, thank you, Dr. Tracy and Salwa, once again for a very informative talk and for your responses to the questions. I'm going to go now to Kaula Barley. The questions, I mean, I think this was very, very fascinating, particularly working myself in intellectual disability services. So one of the questions was, were there any exclusion criteria in terms of the level of disability in the people who took part in the program?
Yes, absolutely. I can hear.
Okay, perfect. Thank you again, Bruce, for a very, very fascinating talk. Again, olfactory reference syndrome disorder. I must admit, it was not something I would come across earlier.
Don't feel guilty.
You learn something every day. So really, thank you for that. A few questions have come in. One is from Aisha Afzal. So is olfactory reference disorder more common in people with ASD?
It hasn't been studied, and I work in an unusual clinic, so there's no literature on that, and I work in an unusual clinic that I think is skewed to getting patients coming through who have ASD plus another anxiety disorder. And I'm just trying to think about through my current caseload. They're all on the autism spectrum, but this is definitely not the full picture. There's no doubt that there are many people with olfactory reference disorder who are not on the autism spectrum. I just get the slightly unusual tip of the iceberg ones, but all of them in my clinic are ASD, olfactory reference disorder cases.
Yes. I think it's understood. I mean, it's quite complex as it is, I think. And I guess the people who come to you would have quite significant comorbidity. So I think that you're probably absolutely right on that. Next question is from Urvashi Panchal. So would you consider BDD to be a symptom of eating disorder or anything comorbid to an eating disorder?
I definitely don't consider it a symptom as such. I'll expand. Of course, many people with eating disorders have difficulties and other image-related concerns that don't just relate to weight. It's important to remind the audience that the diagnostic criteria for BDD expressly state that if you view your image problems would be all sorted by losing weight, you don't have BDD, you have an eating disorder. So it's just important to state that. The BDD diagnostic criteria are quite different to anorexia nervosa. You definitely get a group of people with eating disorders, clear eating disorders, who also have body dysmorphia. And it's actually very common. Folks say 20–30% of anorexic patients might actually have BDD. Now, we work very closely and shuttle patients backwards and forwards between our team and the National Eating Disorders team. And the clinical picture that I often see, and we're kind of feeling as a bit of a care pathway, is that once you start to normalize weight for people with low weight anorexia nervosa, is when you start to see the BDD emerge. So clearly disordering additional concerns about behavior. And it's important that you do the refeeding, because we know that psychological therapy and CBT based on extinction learning, exposure therapy, if you like, we know that that doesn't work well when people, young people or adults, are starved. So our care pathway, we have a low weight care pathway, normalizing weight and then treating BDD, and the same for OCD. So they often coexist, but I see them as distinct, and the diagnostic criteria make it clear they are distinct.
Thank you. That's very clear. Very clear. Next question from Zuhair Dabag. What is the effective treatment for resistant OCD?
It's a very good question, and we could do days seminars on that. So lots and lots of things. And I think the key thing and the repeated message, multiple groups have published on this, is clear adherence to quality psychological therapy. The most common thing that we see in a so-called treatment resistant case is not sticking to clear practice parameters of CBT. So just to illustrate, the practice parameters are slightly different for young people as to adults. For instance, in young people, one of the things that we know from research makes a difference is including parents in the session. So I meet stacks of people referred, they're said to be treatment resistant, they've had CBT and no parents in the session. So the kids go home, the parents don't know what they're doing, and they're not there to really encourage in the right way the treatment. People being scared or not knowing how to do exposure-based work for different types of obsessions. So I mentioned that forbidden thoughts, violent and sexual thoughts, they occur in about 1/3 of people with OCD in childhood or adulthood. And people are very reticent and don't know how to do exposure-based therapy for those sorts of things. We published a paper where we took a set of patients who were clearly referred as treatment resistant and under weird contracting rules were deemed to be treatment resistant, and actually sticking properly to the basic protocol of our manual got them all, matched the other thing. A brief word for the medics in the room. There are things that you should do and consider doing with medications. a 3-month high-dose trial of an SSRI to a second SSRI at high dose. That's the important bit, if treatment resistant. And then at that point, you've got the choice of either switching to clomipramine, dreadful drug, loads of side effects, ECGs, hate it. So what I do is then add a low dose of antipsychotic. But that isn't as powerful as getting the CBT right. Sorry for the waffling answer.
No, thank you. That's very useful, because I think this is something that a lot of people will come across in their clinical practice. And I think your point about adding an antipsychotic, I think that certainly works well in my experience as well.
Can I say one other thing? I'm desperate to say it and I missed it out. That probably the commonest thing that people get wrong in CBT is taking a person into a session, knowing that they need to do exposure-based work and describing it, saying, what I want you to do when you go home is touch the door handle because you think it's dirty. It is the #1 failing. If you don't do the in vivo exposure and doing it yourself, modeling that you can do it, it's so frightening, some of those exposures. People don't go home and do it. So in vivo exposure and psychological therapies is the #1 thing, in my view, that people often get wrong in their CBT for OCD.
Perfect. So are there any specialist OCD